I've been trained and my appreciations few of them, and nothing to disclose actually for this presentation. So today I will go through the subtype distribution of lymphoma in Bangladesh and the diagnostic approach. And then I will start with the 4 case-based challenges in the diagnostic and management approach and based analysis, reflecting thus we have done 226 retrospectively analyzed the patient of lymphoma. So what you have found that in our institution, among that period, among 226 lymphoma patients, the majority were DLBCL aggressive lymphoma, followed by the PTCL and lymphoblastic lymphoma. But in other countries like US and Europe, this is the data of US, they have the almost equal number of the DLBCL as well as the follicular lymphoma, whereas we have follicular lymphoma much lower than this. So whenever we talk about the lymphoma diagnostic, it always should be started with the history and examination and the CBC and PBF, but diagnosis must be confirmed by surgical biopsy, histopathology, and immunohistochemistry. Sometimes surgical biopsy is, if it is not accessible, then we have to do the core biopsy or endoscopic biopsy, but that should be in selected cases. And in few cases, we need to do the FISH studies for proper contouring the lymphoma diagnosis. And for staging, we have done, we usually has to do the lot of investigation for the staging, but FDG PET scan, which is the standard of care for staging of lymphoma, is not readily available in every city of the country. And even in Dhaka city, this is due to scarcity of money and center, the patient often cannot access these facilities. So these are the challenges, starts from the diagnosis. So I will start with the case. The patient, he is 26-year male who presented with fever, dry cough, and breathlessness. He was admitted in a specialized hospital in the Dhaka city. On examination and chest X-ray, he had left-sided pleural effusion. His CBC and blood workup initially showed unremarkable. In spite of getting broad-spectrum antibiotic, his fever was not subsided. And so the doctors over there started with the anti-TB with steroid. And later on, they proceeded for the pleural fluid analysis, which showed exudative and lymphocytes were present, and pleural biopsy showed mesothelioma. So was this a case of the mesothelioma or something else, which presented with the fever and breathlessness? So when the patient referred to us, we approached that patient had increasing amount of the node, liver and spleen where everything was normal inside. And CT scan of this patient showing, you can see that huge mediastinal widening and pleural effusion is there. But we could not be able to take the biopsy because due to deep-seated tissue, approaching the mediastinal core biopsy, it was not possible to do inaccessible site. The pleural fluid shows very high number of the cells with the 7,000 count, and mostly it was lymphocytes noted by the lab. So when we did the smear of this slide, so you can see that all of you can agree with that these are lymphoblasts. So 95% of those all are lymphoblasts confirmed by the flow cytometry of the pleural fluid. Those were actually T lymphoblasts having the cytoplasmic CD3 and other T cell markers, and with the TDT, that is the immature markers. So finally, he was diagnosed as a case of T lymphoblastic lymphoma. The diagnostic approach, why this is important? Because the treatment, this treatment is should be the acute leukemia-like treatment. If we treat this patient like other lymphoma, this patient will get relapse. So after having the acute leukemia protocol, he responded very well, and now he is crossing the maintenance for the 16-month. Patient is in good remission and quality of life. So like this, now several patients have been diagnosed for the severe superior vena cava obstruction, which is a medical emergency due to either DLBCL or Hodgkin's lymphoma. These are really a diagnostic and management problem. Because sometimes due to lack of emergency management in the general ward, we are not able to make all patients survive. This young boy died due to severe respiratory distress. So the take-home summary for the lymphoblastic lymphoma, among the all LBL, 80% are T lymphoblastic lymphoma, which are highly aggressive lymphoma, high-grade lymphoma, and highly curative as well with the intensive chemotherapy. And PFS and OS are better than acute leukemia. And this sort of patient should not be treated with the CBC and the bone marrow and MRD. So they should have been treated and followed up by the FDG PET scan. Again, this is the problem in our country, that patient cannot do often the FDG PET scan as they should do in a schedule. So our second case is primary CNS lymphoma, which is also a challenge in the diagnostic approach and for the treatment as well. This young man who is like 50 years of age, who presented with walking difficulties and severe headache. On MRI, there was huge density, mixed density lesion that you can see in the MRI picture. And this patient, when went to the neurosurgeon, the neurosurgical procedure was done, and the final diagnosis was DLBCL with non-GCB after immunohistochemistry. And these are the lymphoma, which is the primary CNS lymphoma, should not be treated by R-CHOP or traditional chemotherapy that we usually give to the other DLBCL patient. So he was treated with the rituximab and high-dose methotrexate and high-dose Ara-C-based treatment, and which have been proved that the management of the PCNS lymphoma, according to ESMO guideline, we have seen that matrix protocol, which is the standard for young fit patients, and gives the overall survival higher than other lymphoma patients, other lymphoma approachment of treatment. And with the CR rate is 49% and objective response rate is 87% with 2-year progression-free survival around 61%. Number case 3, he is an elderly man who presented with severe anemia and splenomegaly. Eventually, you may think of the elderly man who presented with the splenomegaly and severe anemia could be a case of myelofibrosis. But actually, this is a man of 80 years who came for fatigue and tiredness for 3 months. On physical examination, severe anemia and splenomegaly was there, which was 8 centimeter enlarged from the left costal margin. And his CBC was reported like acute leukemia, because his total count was very high, around 250,000, and hemoglobin was low, 5.8 with thrombocytopenia. But his general condition was not as toxic as it should be in the 250,000 count of the acute leukemia. So this is the picture of very high count with acute leukemia. Several times it was reported as acute leukemia. Approaching this patient, when we did the bone marrow study, we have found that this is very hypercellular marrow with 90% are the blastoid lymphoid cells. So these are looking mature but blastoid. And on flow cytometry, it was confirmed by the mantle cell lymphoma having the B cell marker allowing CD5 positive and negative for CD200. And this is the high-risk patient definitely due to the morphology, but what could else we should do? Like Ki67, genetic mutation for 11 and 14 translocation and the TP53 mutation status. But this could not be done because patient had severe financial constraint. So regarding the treatment of the mantle cell lymphoma, so this is the another type of lymphoma that should not be treated like other lymphomas or other B-cell lymphoma. This is quite different. For the young patient, there is a protocol, but for this patient who is old but patient is fit, so this patient was treated with a rituximab and bendamustine, and followed by he should be treated, continued with the rituximab maintenance for at least 2 years. So this is the standard approach for this age group patient of mantle cell lymphoma. Even then, this is the blastoid mantle cell lymphoma. So what is mantle cell lymphoma? It is the 2 to 10% of all non-Hodgkin's lymphoma, and blastoid variant or morphologically or leukemic phase may be seen in 10 to 20% of cases. And translocation 11 and 14 is the actually the hallmark of the disease. For the young patient, they should be treated with the intensive chemotherapy, RDHAP, alternating with the RD HAOX or oxaliplatin containing chemotherapy, alternating with the ARCHA, followed by the consolidative autologous stem cell transplantation. This is the standard of care. An elderly patient should be treated either with the bendamustine and rituximab protocol or BTK inhibitors, followed by maintenance with the rituximab for 2 years. So case number 4, this is the last case, who was a 75-year man on routine health checkup. He was found to have mild anemia with mild thrombocytopenia. He doesn't have any other complaint. He went for a surgery for his prostate problem, but just for coming the routine health checkup, which was a planned surgery for benign hyperplasia. So he came for the routine health checkup, and it was anemia and thrombocytopenia. On query, he occasionally gave the history of dizziness and fatigue. His ESR was very high, that is the 140 millimeter in first hour. Other parameters and general examination, other systemic examination, everything was normal. So what is the next approach for him? So when watching the very high ESR at this age group, we did the protein electrophoresis, and you can see that there is a big monoclonal spike, and that is the monoclonal band, which is the IgM and kappa monoclonal band. And the total IgM was 15 gram per DL. So watching the bone marrow, his bone marrow is very hypercellular as well, and the mature lymphoid and plasma cells both are increased, along with the mast cell was increased. You can see the mast cells are black in color here. So further flow cytometry was being done, and this confirms that there were clonal B lymphocytes 70% and clonal plasma cell was 18%. So the diagnosis was lymphoplasmacytic lymphoma or Waldenström macroglobulinemia. So giving the treatment, we have to assess the patient, risk categorize the patient, and whether the patient has low risk disease or high risk disease. This patient has low tumor burden, so he can be treated with the combination of the rituximab with alkylating agent like cyclophosphamide and bortezomib, that is the DRC or BDR or bendamustine rituximab. Any of the protocol can be given for him, but bendamustine and rituximab is reserved for those who has lymphadenopathy, organomegaly in the Waldenström macroglobulinemia. Those patients with having hyperviscosity, they can be treated rituximab later part or at least second cycle. From the second cycle, due to rituximab can flare the IgM and viscosity. So you can watch these two patients who were transformed from the low grade to Richter's transformation, and due to there was no proper documentation of the previous diagnosis. So lack of awareness, lack of poor referral system, actually, this may lead to this kind of bulk disease and transform to the follicular to the or lower grade lymphoma to the very high grade lymphoma. So how can we overcome? If we combine all together, if we can make a one-stop center for the lymphoma or in a cancer center or a hematological center that has well-managed lymphoma team with good teamwork, starting from the well-trained working team, hematopathology, immunohistochemistry, facilities for inpatient, outpatient, chemotherapy, radiotherapy, and immunotherapy facilities, as well as you have heard about the previous two speakers have spoken about the stem cell and the CAR T cell. So all these facilities can we should have in one umbrella or at easy access, so that patient can be sent and we can get the actual result for this patient. So in conclusion, well-managed team depends on the good teamwork, as I said, with all these facilities, and all the team include the hematologist, hematopathologist, surgeon, radiologist, oncologist, and chemo nurses and other facilities also. So only we can then overcome the lymphoma patients fighting, as well as we fight for them, they fight for themselves. So finally, we have a lot of limitations, we have a lot of problems ahead, but we should keep our dream marches on. So that with the current permission of the patient, I have shared these two cases. This is the boy who was only 17 years when he was bone marrow transplanted at 2014. Now he is a young man. 11 years have been passed after the successful bone marrow transplantation for relapsed DLBCL, and he is a patient who is maintaining his family after completion of the rituximab maintenance therapy for follicular lymphoma. So thank you very much for patience hearing, and thank you very much for giving me this opportunity to be here in front of you. Thank you.